In this video, we'll be discussing about fluid deviation. Fluid deviation is not that rare as you think. When we are doing phaco and we are using higher intraocular pressure, the fluid is continuously going in the anterior chamber and through the weaker zonules, it may reach the Burgess space which is between anterior hyaloid and posterior capsule. The predisposing factors for these are high bottle height or IOP during phaco, zonular weakness, and abnormally small or large eyes. As the fluid keeps on accumulating in this Burgess space, as the fluid accumulates in this Burgess space, the posterior capsule becomes more redundant or it will start pushing itself forward. So there will be more undulations of the posterior capsule seen. There will also be some particulate matter in the Burgess space which can be visualized while doing phacoemulsification. Both the signs indicate that the fluid deviation has started. So it is important to detect fluid deviation at this stage and reduce IOP or bottle height. Also reduce the vacuum and flow rate during the surgery and use protective viscoelastic and perform very careful slightly anterior phaco so as not to damage the posterior capsule. But if it is not detected and the surgery is continued with the high bottle height, the fluid accumulates further and starts pushing the lens capsule forward and making the anterior chamber shallower. This will further push the iris also anteriorly and it will further result in acute intraoperative rock hard eye syndrome AIRES. Attempt to continue the maneuvers in the anterior chamber at this stage will result in further iris prolapse. The posterior capsule may also get damaged during the maneuvers. At this point, the posterior capsule is bulging forward and we have to do something to rectify it. So option number one is to aspirate this retrolenticular fluid by using 24 gauge needle through pars plana route. For this, we have to be careful that the needle is exactly in the Burgess space. But many times, the vitreous may get entangled in this 24 gauge needle and may result in vitreoretinal traction. Option 2 is to use the vitrectomy probe through pars plana route to cut the vitreous to reduce the intraocular pressure. Also, we can cut the anterior hyaloid so the fluid accumulated in the Burgess space is released. Thus, the anterior chamber can be formed again and we can continue with regular phaco. But sudden decompression of the vitreous may also have higher risk of developing suprachoroidal hemorrhage. Option 3 is to stop the procedure, close the incision, and then we can start the patient on IV mannitol or oral Diamox or acetazolamide to reduce the intraocular pressure. We can take up the patient next day or once the anterior chamber forms again and the fluid in the Burgess space is dissipated. This is the safest method for beginner surgeons with less experience. So let's look at this particular case. The surgery was going on as usual, but the surgeon noticed there was shallowing of anterior chamber. So the surgeon stopped and replenished the anterior chamber with OVD, trying to push the pieces back into the bag. The vacuum of the phacoemulsification was further reduced and the phacoemulsification resumed. But still, the posterior capsule was bulging forward. So the vacuum was further reduced to provide more safety for the procedure till the last piece. The vacuum was further reduced for the last piece, but despite that, the anterior bulge of the posterior capsule and movement was noted at the time of last piece emulsification. And as you notice, there is no fluctuation of the iris indicating it was only anterior movement of the posterior capsule. During cortex aspiration as well, more redundancy of the posterior capsule was found, and also few debris were seen floating in the retrolenticular space. As you notice here, while doing cortex aspiration, you could see the lines on the posterior capsule indicating the anterior bulge. We can also see tiny debris in the retrolenticular space. And the surgeon has to be extra careful not to catch hold of the posterior capsule by mistake. Now, for even posterior capsular polish with very minimal vacuum, you can see that it was holding the posterior capsule because it was anteriorly bulging. Fortunately, the intraocular pressure was normal, and the surgeon could finish the surgery with IL implantation. But it is important to detect the fluid deviation. To avoid fluid deviation, we must avoid high IOP for prolonged period during surgery. Use mechanized pole for gravity-based machines or IOP controlled systems. In case of fluid deviation causing shallow AC and positive vitreous pressure, you can close the case and operate next day after controlling the IOP. Or there is an option of doing pars plana controlled antivitrectomy as well as removing the antihyaloid to reduce the vitreous pressure and then continuing with the surgery. I think the most important aspect of avoiding acute intraoperative rock hard eye is to detect the fluid deviation in the earliest phase. Thank you.